Thank you. Okay, all right, so let's go ahead and get started. Welcome, everyone. This is the December edition of the UIC Global Health Colloquium. Once again, this is a colloquium that is co-sponsored by the Colleges of Medicine, Nursing, Applied Health Sciences, Pharmacy, Dentistry, Social Work, and the School of Public Health. And our goal is to sort of feature scholars and practitioners who engage in global health activities and research. I'm Rohan Jeremiah, Interim Associate Dean for Global Health in the College of Nursing. And as we continue to commemorate the 2022 World AIDS Day, we are very excited to welcome Dr. LaRon Nelson, who is Associate Dean of Global Affairs and Planetary Health at Yale School of Nursing. In addition to that, he's an Independence Foundation Associate Professor, as well as Director of Justice, Community Capacity, and Equity in the Center for Interdisciplinary Research on AIDS at Yale School of Public Health. Dr. Nelson's domestic and international research activities, research investigates the implementation and effectiveness of multi-level intervention strategies to reduce race and sexual-based disparities in HIV outcomes. He's recognized as the world's leading authority on the application of self-determination of theory for HIV prevention and care. And his research also involves identifying interventions to address intersectional stigma at the organizational level and treating traumatic effects of intersectional stigma that manifests at the individual level. Dr. Nelson is the co-founder of the Central and West African Implementation Science Alliance, which is a collaboration of implementation scientists as well as implementation agencies from Cameroon, Congo, Ghana, and Nigeria, which aims to improve HIV-related outcomes among adolescents in the region. He's also leading implementation science efforts to reduce racial disparities in HIV incidence, treatment, and viral suppression among African, Caribbean, and Black communities in Canada. His work also has a US focus, which also looks at the use of multi-level interventions to reduce HIV infections among Black MSM in the United States. Just a quick protocol before we allow Dr. Nelson to start with his presentation. He's going to present, and then afterwards we will have a short Q&A where folks will have an opportunity to ask their questions by raising their hands on their screen. So once again, welcome and thank you for joining us, Dr. Nelson.
Thank you, Dr. Jeremiah. It's my pleasure to be here. Thank you for the invitation. I'm excited to talk about this work, particularly because it's underway, and it has been such a sort of long, complex journey in trying to figure out the best ways to address the issues that we're seeing. And so this is the title, Love and Freedom, thinking about ways to get towards an integrated social, structural, and behavioral approach to HIV prevention among gay and bisexual men in Ghana. I say West Africa just to distinguish it from Guyana because sometimes my accent confuses people. So I'll start this talk sort of as any good presentation on an African country should start with a story. And my background is in public health nursing. I was a nurse who's only ever worked in public health, to be honest. And many years ago, I worked in a sexual health clinic. This is me, if you can believe it. And a lot of work I did was with women. Women would come to the clinic because they had a sexually transmitted infection, or they thought they had one, or they had an exposure and they wanted to figure out if they had one. And we didn't only see women, but I saw a lot of women. And it had occurred to me that a lot of what I was seeing as the nurse didn't compute. It probably didn't compute because I never lived my life as a woman, and I'd never been a young woman, which many of the people that we saw were. And so I tried to understand a bit more about what I was seeing in the clinic so that I could be a better clinician, a better service provider. So I read this book. Jean Baker Miller, who's a psychologist, wrote a book called Toward a New Psychology of Women. And it was a very critical turning point in my practice in public health, but also in how I approached research. And that is because Jean Baker Miller and that institute really talked about connections, right? That connections are things that people grow through and that people grow towards connection, which was very different from how I've been trained, which is that the sign of growth is differentiation and independence, and in some ways disconnection. And that it was actually how I approached my work in the clinic. And I think at the time, how I was thinking about research is very individual focus on the person only. And so they were proposing something very different, in that instead of trying to only advance or essentially advance this idea of differentiation and independence only, that more opportunity lied in the development of relationships. And that relationships was an active state of being in a relationship. It's not an outcome, or it's not a product. And so that was profound for me as a young nurse working in a public health department, trying to figure out how to reduce the symptoms that young women in particular were coming to the clinic with me to see. So that kind of took over. I could not stop thinking about connections. Everywhere I looked, I saw the connections, or I saw disconnections, and I was really preoccupied with trying to figure out how to address them. And one of the things I did was read a book about the human connectome. It's really a book about how the brain is networked and what that means. And there were a couple key things from that book that also guided my work, including my work in global health. And that was this idea of looking at structure and the complexity of the structure and what it meant for the behavior of the individual. So these are just two excerpts from that book. It's mentioned that an organism's behavioral repertoire, right, the things it can do or the things it cannot do, is shaped by numerous structural and mechanical constraints. We all can get that. The way some of our arms are shaped, there are parts of our back we can't scratch. And some people may have arms of different shapes that might allow them to do things that many of us cannot do. But also the anatomical organization of the human musculoskeletal system supports stability and adaptive control of body motions and behavior. That makes sense. But what it also helped me understand at that time is that understanding how something is structured was foundational in some ways to understanding behavior, but it was not sufficient. That there were other things that we had to investigate, questions of functional patterns, not just how things are structured, or not just how networks are structured, which is where this all started. So where do networks or these patterns within networks or these connections emerge? When does that happen? Where does that happen? Quite literally, where do these things happen? Why do they emerge when we see them? And how are these patterns influenced by both structure and then ultimately, which is also my fascination, I think, as a nurse, is to figure out how we can intervene to have an impact on them. And so it helped me understand that structure only was a very important picture to get. But this is what it shows you, right? There's key info that you can derive from that. But I also understood that we had to understand how does structure function, that it's not just something that's in the background, that it is actually serving a purpose that either facilitates health, or maybe I shouldn't say it's either or, but it either facilitates health or constrains people's ability to attain their health goals. So I started my research career after having sort of read and thought about this and seeing some of it in practice, trying to understand networks of people and relationships and identifying disconnections and misconnections. And then over time, started to try to understand the connections between networks of people and networks of systems that they rely on for care, like to prevent HIV or to treat HIV. So this led me to Ghana. There's a whole nother long story about how it ended up first going to Ghana, but I won't bore you with that. But in Ghana, at the time, it was I think it was probably the Gates Foundation, but there was a group in Canada, Grand Challenges Canada, who were looking for impossible ideas. Tell us what can't be done, and we'll give you money to try to do it. And so we said, okay, we want to go and study gay and bisexual men in West Africa. And they said, well, that sounds pretty impossible. So we got the grant to try to do this. And it really was trying to figure out what is the structure and function of social networks of men who have sex with men. Even at the time, if you had read any literature, scientific literature, you would assume they did not even exist. That's kind of why you have these silhouettes. Even in practice, many times nurses can tell you they ever met a gay man or a man who has sex with men in their practice. In some ways because they don't disclose, in other ways they don't. That's not an environment that allows them to be sort of open about their identities, their desires, or their sexual practices. And so we started doing this work, trying to understand the structure and functions of social networks of men who have sex with men in Ghana, and then thinking through the implications that has for HIV prevention. These are just two articles that we published from that, including an article in PLOS ONE that looked at the ways that networks predict condom use among men who have sex with men. So a big issue in Ghana, but as from many other places, including the United States and Canada, is stigma and discrimination. Has an important impact on the ability for sexual minority men to get care. And so a lot of this stigma is intersecting. So maybe the major obstacle is HIV stigma for both primary and secondary prevention. Even among people who don't have HIV, the behavior, same gender sexual behavior, is associated with HIV. There's an assumption that these men are people who harbor HIV or who are responsible for HIV. So there's a stigma almost automatically carried when somebody identifies themselves, if they identify themselves as MSM. That also goes along with hostile attitudes toward same-sex behavioral practices, which is very common in Ghana. Not just behavioral practices, but also same-sex desires, same-sex relationships, and as well, this gender non-conforming stigma. What do I mean? In some ways, the stigma that men who have sex with men face is not necessarily even about the same gender sexual practices. In some ways, it's about men who are not conforming to what the local expectations are about who a man is or how a man should act, particularly if men don't conform to gender norms that say you should be as less feminine as possible or as masculine as possible. That's very common. And so these are also intertwined with beliefs that HIV still is a punishment for same-sex behaviors and a punishment for not acting like people may say a man should act. And so when this happens, MSM are not, these men are not gonna go into clinic and tell you what you might need to know in order to provide, to respond to their healthcare needs. We studied this in Ghana. This is a paper on AIDS behavior about barriers and motivators and facilitators in engaging in care among men living with HIV in Ghana, men who have sex with men. Another study where we looked at men who would dare to go to clinic and talked about generally positive experiences until the nurse or the physician, although it's usually been the nurse, finds out that they are a man who has sex with other men, then everything changes, their experience changes. These are just some examples, some quotes from a study that we did. This one is from a focus group. Guys, one of them is saying, when I went to the hospital for a checkup and my friend was there with me, But the moment I got there, the moment I got there and wanted to talk to the doctor, the way the woman watched me and watched my friend, the way the doctor talked about partner reduction and usage of condoms, and you still don't get it. He's helping me, but the way and manner that he's talking displays that he's got a problem with the person's sexuality. So another example, this is an interview that was done with the nurse from that study. So the nurse is saying, I believe MSM are people that really need much attention and care. I don't know why some of them are into that situation, but I believe society can help them by education. The interview asks, why do you think that they need help? To be honest, it is clear that they need help. I understand that it is not how it's supposed to be, that it's not natural, and that it's not what we are accustomed to. Even the Bible tells us a particular way, but they choose to go their own way. So I think they need help. This is an example of from a man who was diagnosed with HIV and his experience in the healthcare clinic. When I was first diagnosed, the nurse was very kind. She told me that I should ask my lady to also come to be tested. I told her that this situation did not apply to me. All of a sudden, the nurse demanded to know how I became infected with HIV. I didn't feel it was her right to know. I was not ready. She said that she couldn't give my HIV medications without complete information, but I stood firm. 2 more colleagues entered into the room to convince me to talk. What did you do? Tell me, tell us, tell the truth. God is watching. The 3 of them, it was too much. I broke down and confessed that I am a gay. And this is an example, which you'll see a corroborating example from one of the men in the focus groups who talk about the experience in the hospitals and that it's a place to be avoided. The hospitals in this community, this was actually in Kumasi in Ghana, the hospitals in this community have this stigmatization against MSM. So if they get to know what we do or who we are, it will become a problem living in the community. So normally we avoid this. We avoid the hospital as much as we can. And then we talked to a nurse who was in a different city, Accra, but who essentially corroborated what I just read out to you. The nurse is saying most of them don't come to the health facility when they have problems because they have stigmatization and they don't like to come. We've sworn that whatever patients do, we do not discuss with others. They themselves think that if they come for treatment or services, the nurses will disclose. They are afraid of disclosure, so they don't come. Even when they come, they don't want to keep long, maybe thinking that people will come to know about them. So they don't like to come to the clinic at all. They will be at home instead of coming to clinic for early detection and treatment of HIV. So this is happening, and we're thinking about not just that these are experiences that are unfortunate, that are maybe unfair or unpleasant, but that the experience of stigma is stressful, and that the exertion of that stress on the body has definite immunal impacts for people who live with HIV, but psychological stress impacts for people who may not have HIV, but who may need to go to clinic for screening for STIs, for HIV testing, or for PrEP. And that if this type of stigma exists in healthcare facilities, that this represents a chronic, repeated exposure to stigma, which the human body is not designed to withstand every time. Maybe once, a bear chases you or a woolly mammoth is chasing you, and you expect at some point that situation will resolve. But you don't expect every week to be chased by a bear or woolly mammoth. But this type of sort of extreme stress, people will experience MSM if they have to go to these places where they know or they believe that they're going to be stigmatized. And so this is an example from a study we did in Ghana among 225 men with HIV. And we looked at among those who were delayed HIV testing, delayed diagnosis, which means they already had AIDS symptoms at the time they were diagnosed. and those who were not delayed. And so those who had delayed diagnosis had a statistically significant higher rating, reporting that they had been exposed to HIV stigma in the past. So they don't want to be exposed to it again. And so the risk of that potentially traumatizing experience is too much. And so people evade and avoid care. So we try to figure out what can we do about this? If people are experiencing these negative, stigmatizing situations, is there a way for us to address this? And so the way we started to try to address it was through implementing an intervention. It's called YANSAPO, but it is based on Many Voices, which is an intervention that was developed, tested, and used widely in the US among Black MSM, including maybe mostly African-American MSM. It's a best evidence intervention from CDC for increasing rates of condom use and HIV testing. It addresses behavioral and social determinants of risk, and we needed to adapt it for use in a Ghanaian cultural context. This was principally because of a connection I had with an organization, Priorities on Rights and Sexual Health, who talked about the structure of HIV prevention also being stigmatizing, because they said all they talk about, all our funders talk about, all the government agencies talk about is condoms and lube, condoms, lube testing, condoms, lube testing, and that the men are more than just vectors to either block infection or treat infection, that they're humans, that they have desires, that they have feelings, and we have to attend to that. And so, and they also experience pressures that get ignored or that are not addressed if the attention is only on condoms, lube testing. It advances a public health approach, but it can be dehumanizing. And I think in this example, what we were hearing from them is that it was very dehumanizing to even engage in public health interventions because it ignored people's social realities. And so we supported implementation of YANSAPO in Accra with 57 people. We did this in a weekend format. We took people out of Accra and took them to a private area where they could spend the weekend going through this intervention. We had 57 people who started, and we had a little more than half who completed the post-intervention survey. And then we also did a follow-up focus group to understand people's experience of the YANSAPO, particularly in thinking about, is there ways we can sort of test this? And so what you're seeing is an excerpt from the qualitative component of that study, which is published in Global Public Health. So these are, I'll just go through quickly some of the main themes. The first one was that the retreat provided new opportunities for developing and leveraging social support among MSM. This is one quote that supported that theme, is that YANSAPO connected me to other people, not in the sense of going around for sex. Some of us always think that anytime you're in a group among MSM, that all pertains to sexual encounters. Here it's given me more friends that I can freely interact with. For instance, in our group, we can chat to relieve stress and teach people where you all have your information, but that it's not creating any barrier, unlike in the real world, where you may have friends who are not like-minded. With them, always when they're talking, you are forced to blend in, to pretend. Meanwhile, deep within, you don't feel comfortable. Within our group, for instance, you can say whatever, nobody cares, because after all, we all know what's up. Another thing about YANSAPO that was important is that the exercises were emancipatory and facilitated social justice, action, and equity. One example was really the ways in which people really felt locked in to gender expectations among the men themselves. And so this is a quote that illustrates that. I think deep within us as MSM, as much as we are trying to run away from societal stereotypes, deep within us, we're also doing the same thing. I think in a way, there is this kind of hypocritical attitude that we have towards ourselves because you see, society will be expecting you to behave in a particular way. When you come within the MSM community, some people are very effeminate, but their sexual preference with the man may not be being a bottom, but yet still some of us think that because I talk like this, I'm always supposed to go bottom. I think it really gave us an insight into how we see ourselves. So this is a person saying that this intervention helped us separate our social identities from our sexual behavior, that I might be a man who is effeminate. That should not determine the type of sex I have necessarily. Or conversely, I could be a man who's very masculine. That doesn't mean that that should determine the type of sex I have to have. So that was some awakening there. I'll just say this quickly also, this is another example of this sort of awakening around gender. This session made us realize that there is no defined role of what a top, the man is what they call a top, should be, or what a bottom or a woman should be doing. A top can be washing and be cooking and going and be doing anything. It's just about understanding. The bottom doesn't have to be beaten or doing the cleaning and the washing and cooking and buying clothes to prove she's a woman. And the top doesn't need to come home and say, where's my food? You haven't washed my socks. You haven't done this. You haven't done that. That's not how it's supposed to be. Then also with regards to STIs and HIV, I realized personally, let's forget about bottoms that are at higher risk and tops are at lower risk. I think we are all at risk. So it's about the man wants to protect himself. So you, the woman, also seeks to protect yourself. If the top is not ready to protect himself, insist that you protect yourself because your life belongs to you before this person came in. That's what should even make you realize no man should control you. So this, again, the point in this is that it's not just about condoms, lube, and testing, but it's really having folks take some control over their life and exercise sort of justice and emancipation about how they live and understand who they are as individuals, including their sexual lives. And then this is the new clinical and social awareness that they got facilitated a more fully informed development of a sort of personally curated HIV prevention, that they understood the clinical implications of what they did better so they can make more informed decisions. So this is a quote, somebody's talking about it, one of the exercises called the man of my dreams. So with the man of my dreams, wow. When the exercise was going on, I just imagined things. I dreamed that the person should have round eyes, dark color, a little bit like yo-yo, like swag, not be too tall, not too short. Yeah, he should have a deep voice. It helped, everything helped. And then they said, okay, anymore. And a person responded, people stand a chance to get more risk when they see their dream man, because if you meet a normal person, a regular person, he might protect himself. But as soon as he meets his dream guy, he goes crazy. So this is helping people raise awareness about what they might be doing in the moment. Again, not just about condoms, lube, and testing. It doesn't exclude that, but it brings in more people's social reality to help them understand how their feelings, how their emotions, how their desires could complicate their HIV prevention goals and ways to think through that together to optimize their own outcomes. And then the last two was that the approach they liked, it was very participatory and interactive. That was something that the Ghanaian guys demanded, so we built that in. And that they thought the experience could be improved by enhancing the use of time, virtual platforms, and care coordination. So at this point, we realized that we needed something that was multi-level. Even if you can think through some of the quotes that I read to you before, that the issues that are impacting the men are not just individual level focus. And so we started by, again, taking that input about using a virtual platform and developed an intervention called Hive 3, HIV empowerment, education, and empathy. My colleague, a student at the time, Ade Ogunbaju, developed, he's a Beyonce fan. I think that's what his Hive 3 came from. But I get it. HIV empowerment, education, and empathy, those are the 3 E's. It's based on the peer support model of Cindy Lee Dennis, who's a faculty member at University of Toronto, Bloomberg Faculty of Nursing. And it addresses 3 issues: informational support, the facts first; emotional support, showing I'm here and I care; and affirmational support, demonstrating to them through these interactions that their life matters. And we use local peer mentors to nurture resilience among the men who get exposed to stigma in many settings, including healthcare settings, and to help mitigate the internalization of that stigma, which you heard in some of the quotes. And so each peer had 10 clients that they supported. And that was something that was very well received and worked well. We also were very interested in figuring out how can we address the stigma that folks experience in healthcare facilities, because that is where the rubber meets the road. It's where you, at least at that time, where you sort of had to go for prevention or treatment services. And so we developed client-centered community care coordination, or C5, which was a web-based platform that was optimized to use on smartphones. And we based it on self-determination theory, kind of like most of the stuff I do is based on self-determination theory. But the goal is that it was to support clients' autonomy, to help them be in control over the timing and the focus of the healthcare encounters, to support their competence, providing informed resources to help them achieve their goals. And perhaps the most, maybe not the most important, but very important, is relationship support or relatedness support, to demonstrate that we cared about them, that it mattered to us what happened to them, and that they could achieve their prevention goals. So this was web-based. We did this, but with men who were living with HIV. It included an HIV symptom self-report and monitoring. We called it Auntie's Corner. That was a name that we got from the guys in Ghana, because the auntie in Ghanaian culture, but I think probably also in African-American culture, is a confidant, somebody you can go talk to about stuff that you can't always talk to about your parents. And you know they're going to give you the right advice and they're not going to share it. And so this was Auntie's Corner that we did. These are the aunties. This is Joe and Emmanuel. Emmanuel doesn't identify as a woman or auntie, but he's a nurse, and he's worked with MSM, and so he was one of the two nurses behind the scenes in Auntie's Corner. They were the ones who were monitoring chats from the men and evaluating the symptom reporting that they did and offering feedback to the men. Again, the goal of this was to try to reduce their exposure to stigmatizing environments, because they told us that the clinics they go to stigmatize them. So we said, well, let's create another situation where they can get access to a nurse that we've trained, that we know will be affirming and not stigmatizing. So we did a study on this, piloted it. Each participant was enrolled for 60 days. There were 61 of them. These were men who all had HIV. That was confirmed through an HIV test, and we did this in Accra and Takoradi. We issued the men smartphones because we had developed this app. We wanted to make sure everybody could use it, that it didn't vary by the devices that they had. We asked them to report their symptoms every 2 weeks. That was 4 times over a 60-day period, and we used an HIV symptom distress index to understand how bothersome the symptoms were. So we found in that 85% of the clients contacted the nurse at least one time. So 52 of the 61, which was good. We know that at least they would use it. The average number of contacts was 14. The minimum was 1, and the maximum of those was 93. Some people had a lot of questions for the nurse, but in general, people only contacted the nurse when they needed something. Most of the men in the study, 30 of the 52, contacted a nurse less than 10 times over a 60-day period. So it's not something that would have been overwhelming to a nurse who was monitoring a program like this. 97% of the folks who participated completed symptom monitoring at least once. So this includes people who never contacted the nurse for any consultation. They did complete the symptom monitoring at least once. You can see here that not quite 2/3 of the people who enrolled completed symptom monitoring at all time points. So most completed it at least once, but only about 60% completed it at every time point, which gave us some sense of whether or not that was too much of a burden to ask them to do. But the information was important for the nurse to review and to be able to intervene if the nurse identified some problematic symptom clusters or symptoms that did not resolve over time, that could be the trigger to try to get the man to go to clinic to be seen, where he otherwise just may be trying to avoid going. But we learned some stuff in this. So one, there were technical issues that were identified even after the study started. Even after we did extensive testing on it, we didn't find all the problems in advance. Again, not all the clients responded to messages from the nurse. We realized there was a high education needed in order to use C5. Not all people read, not all folks that participated had formal education. And so that intervention was digital. It used technology that we issued, which might have been more sophisticated than what some folks had access to, and it was in English. But the app did facilitate disclosure of clinical information. The men asked questions that the nurses said they know they would have never gotten asked in clinic, or that they've never been asked in clinic in their entire career. And I think the distance or the anonymity that the platform offered allowed the men to ask questions that they otherwise would be ashamed or afraid to ask in person because of cultural norms. And then they used this function called Show the Nurse, which was taking a picture and displaying that to the nurse to help understand what they were experiencing, which was better than sometimes what they would describe in the chat function, which is, I have something that looks like blueberries, and the nurse can't do anything with that description. So we realized that this probably is not going to be the intervention to move forward because of the complexities with it. And because we were, in a sense, even though we were trying to reduce exposure to stigmatizing environments, we were in a way creating this sort of parallel health system. And where most people were not going to go for care. And we were missing an opportunity to actually change the environments where people were going already. And so we realized that we needed a stigma reduction intervention that targeted change in the healthcare climate in existing facilities, not some online auntie's corner that we made, that the clinics where the guys go, the STI clinics, the hospitals. And that it had to address stigma that was at the intersection of HIV, homophobia, and gender nonconformity. So I didn't do that work. I wasn't a healthcare facility person. So I partnered with LaRon Nyblade, who's been doing this for a very long time at RTI International. And we looked at the intervention that she's been working with called Health Policy Plus. It's an evidence-based intervention that has really been built on over 20 years of research and programmatic work in Ghana, in Vietnam, in Thailand, and in other places, I think even in Tanzania and Kenya. This intervention takes a total facility approach, meaning that it's designed to be done with most of the people who work in a facility: nurses, doctors, security, social workers, lab techs, accounting, and management, because it recognizes that all staff have a role in stigma reduction. It's facility-led, starting by engaging the managers of the facility, the leaders, the staff, as well as the clients. We look at baseline data and use that as the way to show them, to motivate them for action, and then to tailor the intervention that they decide on or that they implement within their facilities. These champion teams that they identify actually implement the intervention activities that they design for themselves based on this new understanding of the ways in which their work stigmatizes. Because what we found is that for the most part, people enter this because they want to be helpful. And it's stunning that they can be surprised when they realize that some of what they do actually is harmful, because they don't want to be harmful. And so that is a big motivator for them to reevaluate their practices. So we took these three things together, HP Plus, we didn't use Auntie's Corner, and paired it with Yantapo and Hive 3, HP Plus being the intervention at the organizational level, structural level, Yantapo being the group level intervention implemented at the interpersonal level, and then Hive 3 is the peer support intervention that's delivered one-on-one. So we use this model to say, if we can put these things together, if we can reshape the environment and motivate men to then go back to the environment, can this interaction be more positive? Can it actually increase the frequency of HIV testing? First, can we get men to try to go to clinics again that they tried to avoid? And if they go, can they have good experiences that will lead to increase HIV testing. And so we're in the middle of, we're not in the middle, we're currently in this trial, but we're ending in the next 60 days. We're collecting our last follow-up data. This is a randomized controlled trial that is funded by National Institutes of Nursing Research. The first aim was to evaluate the feasibility and acceptability of even doing this multi-level, multi-component intervention, which we had not done before, and then to estimate the effect size of the intervention so that we can scale it up for a larger RCT. We're doing this in 8 healthcare facilities, some government facilities and some private facilities. Another thing that seemed quite impossible, even during a time where there's legislation being discussed in Ghana to either further criminalize same gender sexual behaviors in individuals. But we found 8 clinics who agreed to do it. And we're wrapping that up right now. So I'll just conclude in that research that supports freedom and autonomy, which is what we've been trying to do, to really not just focus on the mechanics of HIV transmission, but to incorporate the fact that these are people who have human emotions, and that our interaction with them should recognize that, and that we should also communicate caring, and I say love. I'm not often sure if I mean love, but I think I do mean love, because that is important, especially when they're in situations where that is not in large supply. Science, and I try to demonstrate this through showing this trial that we have funded through NIH, is embracing more complexity. I think 10 years ago, there'd be no way we could propose to try to do a study like this, but it is an opportunity to discover novel solutions that that we shouldn't be afraid to test. The problem is complex, in some ways you need interventions that can match that complexity. Addressing HIV inequities really requires attention to multi-level factors that converge to impact these experiences, both at individual level, group levels, and community levels. And then, although this field is new, this is multi-level, structural, social determinants of health and how you address those, intersectional stigma, all of it is new, but it is maturing. And I think interdisciplinary collaborations with others can help create synergies that can advance HIV prevention science and impact, sort of like me as a nursing scientist working with folks in public health. I think those are nice collaborations that can lead to more advanced than we can figure out by ourselves. This is one of the teams that I work with. Just want you to see them, say hi, and happy to answer some questions about it. Thank you.
Thank you very much, Dr. Nelson. We do have some time for Q&A, about 10 minutes or so. So we want to open it up for folks if they have questions. I see Tersa Pereira has a question.
Hi, yes, my name is Tirsa. I am from Pulmonary and Critical Care. Thank you so much for this excellent presentation. Thank you so much. I do have two questions, and when you were talking about you know, the using the cell phones for the participants to feel more like comfortable asking questions, I remember that in Ghana there has been legislation, very harsh legislation introduced against the community, and I know you mentioned that as well. So how will you work with the roadblocks that can you know, that you could face, right, because of these, you know, legislations? Like, that's my number one question. Like, how will you work with any issues that the government might impose? And the other question is, when using the cell phones, I think it's a great idea, so then the participants feel like more comfortable asking any type of questions. But is there any concern about government monitoring these you know, phone questions? And if there's anything that you could tell us about how to assure privacy for the participants?
Thank you for that, Tirsa. So the discussion about the legislation is a discussion. So it hasn't been, the harsh legislation has not been enacted, but it has had a chilling effect. You know, people are afraid about what might happen. The nurses are afraid about what if I'm seen as aiding or supporting this. So it's not been a tremendous roadblock. It's a political issue, but what we found is that most people that we work with want patients to have good health outcomes and are willing to do what they can to make sure that happens. And they understand that some of these things are making their mission as physicians, as nurses, as pulmonologists, making that harder. And so they've actually, at the expense of doing something that is in violation of the law or cutting close to it, have become very creative about how we can get things done that allow them to not put themselves or their organizations at risk, but help advance the sort of cause of preventing HIV. So we've taken our cues from them. We've had physicians who set up clinics at night. So everybody goes home and then they come back, and that's the clinic for MSM, because they know if the guys come, if they dress a certain way, one, they might have to perform a certain identity that makes them uncomfortable, and then people might still stigmatize them, and they might cause more attention that nobody wants. And so they set up another way to provide these services. And so there's these ways that people, not just MSM, but healthcare providers, resist some of these larger public political narratives around it. And so we hope that we don't have those roadblocks, but I think even if they come, we'll find other ways. I'll just give an example. We had, when we did the interventions, even the one that we're doing for this current trial, we work with police. There are police who helped us know where we could go that would be safe. There are police who patrolled to make sure that there were no people, mobs who were coming to cause any trouble, right? This is at the same time that there's this public narrative about you're going to be arrested, you're going to be killed or jailed, that there are people who are saying this is foolishness. Let's figure out ways to get this done. And so you have this other cooperation that takes place. We didn't have the same concern about government monitoring of the chats, because I don't think it's that serious for them. The bigger concern was that other people might see the chat in their immediate surroundings. So, you know, a family member or a friend. We try to control that through this app that would lock when the person put it down. The screen would go blank and it would lock. The men have opted to actually use WhatsApp. One is something that they're more familiar with, and there's this function of it that is encrypted so that people can't intercept it. And then they have these messages that can disappear so there's not a record of it. So we've sort of leaned into that. That's what they're comfortable with. So that's what we've used to help minimize the risk that somebody's going to see what they're talking about.
Thank you so much.
You're welcome. Thank you for that question.
Questions from the audience? While we wait for folks to speak, I actually wanted to sort of pose a question to you. I noticed recently you just published about a paper which talks about lessons learned engaging with youth around this type of work, of which you sort of put forward some recommendations and thoughts around your experience doing this. But one of the things that you talked about in your recommendations or lessons learned was that adolescents living with HIV prefer not to be separated from other adolescents when it comes to any work or engagement around that. And I wanted to see whether or not you could elaborate a little bit more around that, because I thought that was quite revelation in terms of what you have seen in your work.
Yeah, thank you for asking that. You know, they also see it as, again, a disconnection. And so the adolescents don't organize their lives around who has HIV and who does not. And so the way that I think we structured services to them is artificial. It undermines the things that they sort of need, which is connection with other youth who are who are otherwise like them, other than this one health diagnosis that they're managing. And so there was a resistance of participation of folks who might say, so let's say LaRon has HIV and Rohan does not. And so we go to a place and Rohan goes here and I go there and I say, what's happening? I came here with my friend because we're supporting each other, and that the system has separated that. So people would rather not go than go to a place and experience that disconnection, which undermines the relationship they're trying to build and the support they're trying to offer to one another. I think maybe that has changed over time. Those of us who've been around for a long time, when HIV, when this began, I think understood the need. We believe that it was a way to protect people with HIV, and I think it was in large degree, but I think people's understanding of illnesses and their appreciation for it is different than what it was when HIV first began. And so we've been using those same models, and young people are telling us that it's not useful for them and they don't want it. So that's what we're trying to elaborate on in that article, because across those different sites of the people who were in that study, we found very similar responses from youth in particular, who didn't really respect the models that were based on experiences from the 80s and 90s.
I'm just checking to see if there's any more questions in the chat, so I can continue asking more questions from my end. Another sort of lesson learned that you spoke to was also connecting youth to relevant services, sort of to increase the coordination as well as the quality and the integration of continuum of care. I think a lot of us may have a pretty good understanding of what that means here on the US side, but what does that mean for individuals that are in Ghana or other places? What kind of other services are they more interested in getting help or support with?
Some of it is more and more is mental health related services. The stigma, substance use and mental health diagnoses are high in this group. And I think a lot of it is people reacting, or their bodies reacting to this chronic exposure to this stress, the stigma. In many ways, is very psychologically traumatizing. And people haven't figured out how to manage it. They experience these symptoms of PTSD. And so, and many of these places don't have systems for high quality mental health care. And so we try to figure out what those are and create relationships and be able to connect folks to it, because those are some of the things they need. Substance use is another thing. The addiction, health, or medicine specialty is not very well developed in most places across the continent, but certainly in Ghana. And a lot of people are experiencing addiction. It starts out as something that they need to help them get by, and then it's something that they can't stop. That's one. The other one is related to violence. I guess it's still a mental health form, but not quite a diagnosis, but there's a high exposure to interpersonal violence among the folks, at least in the LGBT community and in Ghana, and needing some support around how to manage their exposure to violence and I think the trauma that is associated with it. The last thing I'll say is income. And there's not a lot of income opportunities, sufficient income opportunities that are around. And so that is something that people, that's a little less sophisticated, I would say, than a US model. But I think when people have those needs, what we see is that nurses kind of know people who can find some work with somebody to do. It may not be a job where you put an application and you get the paycheck, but it's some way that can help people link to services that they need so that they can keep housing, that they can afford to pay for medication that they need. They don't have the same type of insurance systems. It's not a blanket statement, but the systems are very different. But mental health, substance use, violence, and income are, I think, the four main things that people really need help with to stay maintained along that continuum.
Okay, thank you. Last call for questions or comments from the audience. All right, so one last point that I probably would ask you to speak to. I know in this type of work, it can, one of the things that we're always cognizant is the role of the church or religion. So how did you mitigate that? Were you able to find that there are opportunities of allyship, or were there more challenges? How did you sort of work through that in this type of work?
Yeah, that is big. It's a big deal. We tried to avoid it, and we didn't know how to deal with it. And I think we pretty much avoided it. I mean, we tried to say, this is about your responsibility as somebody who works in a facility to provide healthcare, and to not offend their religious beliefs, and to not challenge it, but you can believe whatever you want to believe. We're not commenting on that, but here's what you're here to do. And if you're not doing this, or that is interfering with that, these are the outcomes that are happening, and these are negative. And is that how you want to practice? And I think people, for the most part, could manage the two. They could say, I'm a devout, conservative, Christian nurse, and I don't believe this, but I'm going to talk to this guy and his partner, and I'm going to screen them, and I'm going to give them condoms, because my job is to keep new HIV infections from happening. And so we tried to, we didn't know how to do it. We actually had a Catholic sister work with us, and we end up saying the best way to address it at this point is to not go there, because we didn't have sophisticated theological rationales to offer. We were nurses and public health people, so we weren't equipped to deal with it, but we can't avoid it forever. And we're not trying to avoid it forever, but I think we have to be very careful about going there, because we don't want to cause more problems than we're trying to solve. I hope you understand what I'm.
Yeah, no, I get it. It's a very sort of tricky spot to be in, where you definitely don't want to disrupt too much, but at the same time be able to provide services and support and everything like that. So actually, rather, if there's no more questions or anything, what is your thoughts around the future of this work? Where do you see this going, both from the standpoint of your own activity, but also to just in terms of where you see other trajectories around scholarship and work around this topic is going within the next 5-10 years or so?
I think it's going to grow. I feel like I've been saying this ever since I took that picture with the long hair, and people were saying, oh, you can't, it's a non-modifiable factor. You can't change it. You can't change poverty. You can't. And I was saying, but we have to. Like, if we're going to fix this, we have to figure out ways to change things that we say are not changeable. And, the methods have not caught up with it yet. So I think our colleagues who are methodologists, who are biostatisticians, who are implementation design experts, are going to have to figure out how we evaluate these types of models, because right now we really don't have the tools to do it, that are ideal tools to do it. I think the designs we have, the RCT design, worked for some things, doesn't work for a lot of other things. And so we have to rethink it. But, I think the NIH, which is what I'm most familiar with, I think there's this recognition that we're in this paradigm shift, and that we can keep going the same uni-level behavioral way, but we have decades of data to show it's not helping us sufficiently to address these inequities, and we have to try something different. Even in the absence of robust evidence that these things work, we haven't tried it before. We don't know how much it works. We're still doing experiments, but the appetite for that is there. And I think there's a window, at least now, where I think if folks have an inclination that they got to do something more complex, more risky, that you can do it. And hopefully some of these tests that people do will provide evidence that show efficacy and we can scale these things up. But I think this is an unusual moment. I think COVID helped that. Why am I saying that? I think when people could quickly see the disparities in COVID and how they broke down by economic and racial lines, it poked a hole in the idea that these disparities happen because people behave differently. And it's not just that they behave differently. The folks live in structures that distribute risk, right? And so this is partly because of behavior. I guess you got to breathe in a virus, but part of it is structure. And so I think that helped scientists and funding agencies realize that we have to take this seriously, because it's not just activist people, yelling about it, that you can really see it. HIV was harder because it takes longer to get HIV, but you can see that in a 3-month period with COVID, it was undeniable. So I think this has a lot of promise if people are interested in going in this direction. I would encourage it. We need more people thinking this way.
Okay. And I said that was the last, but I actually do have one more. And one is for you to reflect a little bit about your role being trained as a nurse and also nurse scientist doing this kind of work. What sort of advantages or perspectives that you bring to your research team that is sort of advantageous to this work?
That's a very serious question. I think, in a large sense, I think my appreciation for how human beings react and process is what I learned from being a nurse, working with patients who say one thing and do something else. And for me, not to see it as a contradiction, but as complexity of the human condition, in ways that I think it's harder for other scientists who aren't trained in that, who say, why aren't I designed this? How come they aren't doing it? Because they don't. That's just not what they do. And so we have to think about, how do humans live and process and all the peculiarities of it? And we have to design things that respond to that, not based on what we think people should do. Because it would be easy, but it's not. And I think being a nurse has allowed me to be comfortable with that, not to be stressed out, not to penalize or judge people who don't do what I have expected them to do, to figure out, how do I support people? How do I offer unconditional support to help people along in lives that are, or psychologies that can be very complex? So I think I do offer that. And there are other things that my colleagues offer me that I don't fully. Let me tell you an example that I don't fully appreciate. So in Ghana, the first study we did in Ghana, I felt like I was being bribed. We were trying to get a meeting. We were doing some work in a village, in a region, and we were going to end up in a couple of villages. And so someone said, you got to meet with the chiefs. You can't just show up in these, you can't walk up in these folks' villages talking to people. So we brokered a meeting with the chiefs, and then they sent us a list of things: $500, 2 bottles of liquor, something else, maybe 3 or 4 things. And we needed to bring this to the meeting. And I was like, this is crap. Like, this is not ethical. They can't do this. They can't bribe us into a meeting. So I had a colleague who was a Africana study scholar, and he said, no. You're not understanding what's happening here, right? Like, these are rituals. Like, you have to be able to abide by the rituals if you want audience with the people who you want to support the research that you're doing, so that you have to do it. Like, it's not an abnormal thing. It's not an ethical thing. It's the thing that you must do if you want to do this work here. I didn't understand that as a nurse, and had that not had somebody on my team who had studied that from a sociological and anthropological lens, I would have packed up and went home and told all these people about how I was being bribed in a village in Ghana, right? So I think I appreciate your question,
Yeah.
because I do think there's value that nurses add, but I think there's value in general in multidisciplinary teams, because we all have these professional or disciplinary blind spots that we don't even know what we don't know. And other folks can help supplement that for us.
Appreciate that. Thanks so much for sort of bringing that in. So, as we are running out of time now, I do want to take an opportunity to thank you once again for joining us and sharing your work. It's very enlightening. Also hearing your trajectory and stuff like that. Folks can certainly catch up with your scholarship by looking up some of your publications, but also to reading your profile through the Yale School of Nursing as well as Public Health. A quick end of note to everyone else is that we normally have this colloquium every month. However, there will not be one in January. We resume the next colloquium in February of 2023. So once again, thanks everyone for joining us today. And a special thank you to Dr. LaRon Nelson.
Thank you.
All right.
Take care.